You guys remember the movie Minority Report with Tom Cruise? All right, cool. So that's sort of I think a very germane title for this talk, but it's on MIS TLIF. It's something that I think you'll probably see a lot of in practice. Not you'll definitely see a lot of in practice. It's the workhorse of most um, like private practice spine surgeons for lumbar pathology, but obviously not something that you'll see a ton of this year. And we'll get into some of that. So um, the outline, indications, pros and cons of the various approaches. I think what you'll hear here, what you'll hear outside of this place, and what the truth probably is. I'll do some case examples. We'll go through some technical considerations with the actual steps. And then the one bullet that's not on there is some updates for 2024. So this image, I think you've all probably seen before with the various approaches to the spine. For most of spine surgery, it's basically just that front arrow and that back arrow. And then folks started doing TLIF, and that quickly became, I think, the most utilized procedure. And then obviously lateral surgery, and then oblique approaches from that point. But when I did my fellowship, it was almost all MIS TLIF. This is Rick Fessler, and he was like a big MIS TLIF guy. So I think we did like 2 or 3 laterals the entire year. But it was like TLIFs every day, and it was just a workhorse, and people did pretty well. And I thought that was sort of the way to do things. When I was in residency, we did like open TLIFs, like open one level TLIFs, and so that's what I was sort of used to seeing for like a one level degenerative spondy. Um, and then I was like blown away in fellowship. We started doing MS, like, oh my God, this is so much better than obviously you see lateral and all of that. But when I came here, I kind of felt like I was like an outcast because everybody was like big into lateral surgery. And it's like, what are you doing? And so it's interesting how different practice patterns can evolve at centers and regions. And it's pretty easy to lose sight of the fact if you're from this area or at the end of this year, like how pervasive TLIP is, and it can work, and it's I think it's like 80% of the market share for lumbar fusion or something crazy like that you would never expect. So let's go through some of the different approaches and the pros and cons. So obviously here at SCSF, you'll see a ton of lateral, and for good reason. It's an awesome operation. You get a larger graft, it's still MIS. You can do indirect decompression. It's pretty quick. I mean, you guys spend an afternoon with Bob. You'll see how quick it can be. You can do multiple levels with one approach. You don't need to have any posterior dissection other than just your perc screws. But obviously, you can injure the plexus if you're responsible about it, and you don't push your indications. You listen to your neural monitoring. That can really be minimized. Likewise, bowel injuries, hopefully something that nobody here will ever deal with, but it's possible. Chain injury unlikely. 4 or 5 obviously is sometimes limiting. That's incidentally where I do most of my TLIFs. Obviously, from a lateral approach, you can't get to 5-1. The OLIF can have a learning curve. So that's lateral. ALIF, by comparison, is a great operation. I think you get the best lordosis there. Obviously, you're releasing the ALL, you get large implant footprints, better fusion, less subsidence. It allows you to get a much more physiologic restoration from L4 to S1, where most patients are going to need the majority of their correction. And similar to lateral, you don't need to have a posterior muscle dissection. Hey, TJ, what's up, buddy? Welcome. This is TJ Florence, neurosurgeon at UCLA. He's just coming to get some access to the program, and so take him in like one of our own. So we're doing a brief overview of MIS TLIF, which we actually don't do too much here. So, gosh, I don't know why that's showing up so odd. 1 second. Extend desktop, maybe that. There we go. So yeah. All right. So disadvantages, obviously, vascular bowel injury, retrograde ejaculation, which I think is underreported. You have to do 2 positions. And then this is probably the biggest one, need access surgeon. It's not a big deal to need an access surgeon, but not everybody has an access surgeon. So we are in a somewhat unique scenario where we've got not 1, but 2 really good access surgeons. When I did my fellowship, like a third of the way through the year, we just stopped doing ALIFs because the guy who had been doing our access, I think he got injured, he went on sabbatical, and the replacement was not super trustworthy, at least in my Chinese line of sight. And you have to understand, like academic programs, there's not going to be the same emphasis on like becoming an access surgeon. That's not as like academically interesting. Like if you're a transplant surgeon or whatever, maybe you've got your own like academic interest, and it's not like you're getting a fee for service pay schedule or whatever. So it just becomes a little less palatable to invest a lot of time and energy into being an access surgeon. So in private practice, you can often get really good ones. Sometimes in these managed care settings, you can get really good ones. Maybe ironically, in academics, it can be harder. Not a, apply to everybody, but a kind of a rule of thumb. Limited mostly to 4-1. We talked about this recently. Some folks will get to 3-4. I guess it's even possible to get 2-3, but I think the majority of access surgeons are going to be comfortable from 4-1. So obviously lateral ALIF are really good procedures. And when I came here, it was like, how could, like I showed one or two of these in post-op conference, and I was just getting like totally like brutalized for what I thought were really good operations. Like you can't get any sagittal plane correction, reduction, you can't get any good graft, it takes forever, you can get a CSF leak, they all subside, barely ever fuse. So, there's certainly a bias, but there are advantages to the procedure. And so you can get a great direct decompression, which frankly sometimes is going to be necessary. It can be done MIS, it can be done endoscopically. We'll touch on that a little bit later. It's single position, you have them prone, so you can get lordosis. When I made these slides, prone lateral wasn't a big procedure. Obviously now we have a way to get into the lateral space in the prone position as well, and you get the lordosis there. But patient's prone, the anatomy is familiar. You don't need an access surgeon. There's no risk of bowel injury, plexus injury. It's a small corridor, so you can't get in a huge cage. Generally speaking, I think you get less lordosis correction. There's pretty good literature to suggest that you can get the same amount of lordosis from a TLIF as you can from a lateral, but you have to be thoughtful about it. You can't just like jam in a bullet with like, 10 degrees of lordosis. You have to probably do like a bilateral facet takedown and get the cage out front. And if you do that and you compress, I mean, you can get pretty impressive lordosis on a TLIF. There's no question about it. Potential for nerve injury. What I mean by that is if you are trying to put in a big graft and you're not thoughtful about usually the exiting nerve root, you can definitely ding the DRG, and that can cause neuropraxia, paresthesias, all that stuff. And then subsidence is an issue, particularly with the in vogue expandable cages, and we'll touch on that a little bit as well. So from the movie, there's like, I don't know if you remember the plot, but there's like 3 psychics, and they would predict crime, and then the police would go arrest the person before they perform the crime. But sometimes the third psychic would have a different vision of the future, and they would call that the Minority Report, and that was like the kind of the essence of the scandal. And so that's what this is meant to be. Sometimes the Minority Report, which is doing an MIS TLIF, is actually the right decision, even though I do less of them than oftentimes. So, okay, so when I came out of fellowship, obviously that was what I was most accustomed with. So 4-5 spondylolisthesis, that's still the reason that I most frequently do MIS TLIFs. This case in particular, now I would probably do lateral just looking at it. But at that point in my career, I wanted to do MIS TLIFs, or I was most comfortable doing MIS TLIFs, but I had all these concerns in conference about like getting lordosis, big cages and everything like that. So I was like, okay, well, I'll put in one of the expandable cages and I can really crank it up. So I remember showing this X-ray and being like, wow, this is great. I got a really good lordosis. It's like a big graft. And then the patient came back 3 months with a little bit more back pain, and you can see that the graft like pretty much completely subsided and then went back to a somewhat neutral, maybe even slightly kyphosing operation. So it was a very good learning experience. Fortunately, the patient did perfectly fine. But I think if you're using one of these solid titanium expandable cages with like a rigid expansion mechanism, so like, any kind of crank or anything like that where there's no give, the data suggests that it's very likely that you're going to have subsidence. You're not going to be able to maintain that lordosis. So something to be thoughtful of. And there is a fair amount of literature on this, both this study and then a more recent meta-analysis that I'll share at the end, which basically shows that the incidence of subsidence is a lot higher in expandables, like 20% compared to 5%. So basically a 4x increase. And if you take only one of the facets, then it's obviously much, much higher. So if you take both facets and things are a little looser, then you're going to have a lot less subsidence. And that's basically what shows here on the graph. So on the left side, you've got static. On the right side, you've got expandable. And you can see that the rate is like 6% versus 17%. for violation, and then 5% versus 20% for subsidence. So if you're going to use expandables, think about the mechanism, think about the quality of the bone, and just kind of exercise a little bit of caution. Um, okay, some of my early experience at Scripps, and again, I mentioned that we don't do it a ton here, so you feel like you're a little bit of an island when you're doing it on TLIF because we've got such good vascular surgeons and because we've got such good mentors here who do lateral surgery. Um, so this is a patient who 55 and had adjacent segment disease from prior ALIF and some bilateral leg pain. So here, and I think Tim, you actually wanted to research this, but this is a patient that had an ALIF, and sometimes when you're doing ALIFs, which is not something you have to worry about when you're doing TLIFs, you could have some foraminal encroachment, and it can be from a spondylitic spur, like seen here, or it can be from the SAP. If you put in like a 20-degree cage, you can get the SAP sort of projecting into that frame. And so there are downsides to other approaches. When you're doing ALIFs, you should always kind of look at the morphology of the SAP, see if they have one of those spondylitic bars, and just something to be thoughtful of and kind of pay attention to. So this is a case where I had to kind of go back and actually drill out that little spondylitic bar, and the patient did okay. So ALIFs aren't perfect either. Other thing that I didn't include in this slide that I think has become germane even in our clinic, Tim, is that like if you crank up an ALIF and really increase the height of like L4 to S1, patients are at a pretty significant risk for praxia. Particularly if you're putting in like 14, God forbid, 16 millimeter cages up front, or if they've had like a decompression in the past and there's maybe some like scar or some tethering of the nerve root, and then you jack up the anterior column, then I think that nerve root is really vulnerable. So my recommendation would be try to avoid dramatic increases in the interspace when you're doing ALIFs, particularly in elder patients or patients who've had posterior decompressions before. Figure out what your alignment goals are, and then try to basically minimize how much you have to elevate the interspace in order to achieve your sagittal alignment goals. Okay, so more early experience. So this is a 64-year-old woman, has an L4-5 spondy that you see there, a transitional segment, and the classic sort of psoas anatomy from a transitional segment where you've got the why is it not? I'll try to plug it in again. Sorry, some technical difficulties. All right, let me see if I can. Is that the last slide you guys saw?
Yeah, that one, yeah.
No, we could have told me something. Basically, this is the patient I showed that had the ALIF and had that like classic spondylitic bar. You guys think what are you talking about?
Yeah, I was confused. Talking about that X-ray, I was like, all right. I didn't think that was an A-list.
So this is that case where I was just showing that you can have issues with an ALIF as well. So there's that spondylitic bar, and that patient had to stick a tube back down and basically drill that thing off. So something to be cognizant of, as Tim, I think he spoke about at an earlier research meeting. Okay, so back to some case examples. If the slide stopped, tell me. For 64-year-old woman, she's got a 4-5 spondy. You can see the transitional anatomy there. In my mind, this is like a really good case for an MIS TLIF. And you can see like the lateral approach is just not going to work. She's got that psoas drift, and the plexus is being pulled across 4-5. She also had a bunch of abdominal surgeries. Not that I'd want to burn the anterior approach for a 4-5 at all, but not great anatomy for a lateral approach, and other history that precluded an anterior approach. But she had pretty bad osteoporosis. And so that's one thing that I always kind of take into account. And so you're not gonna be able to get a huge graft in a patient that's got bad osteoporosis. This is pretty early on in my career, so it's before we were so apt at getting folks on Tymlos and Forteo, and so the plan was then to take down both facets and put in two grafts side by side to try to mitigate that point loading of a small TLIF graft. And I always like this picture because it was Ryan Hull, who's in Minneapolis now. It was one of our, he was like, I think the first or second year fellows that worked, maybe. He was a great guy. He looked like he was 12. He was a great surgeon. He was a great guy. And this is just an image of the two of us kind of doing it together. If you ever do try to do this, however, your tubes have to be like almost orthogonal, because if you take that normal like 30-45 degree angle, you're going to be like hitting each other constantly. So you just take a slightly more orthogonal approach, and we're able to put in side by side cages, both kind of working together, and get a pretty good result. And this particular implant is expandable, expands axially and sagittally, but it's got a little bit of like a give in the expansion mechanism. It's kind of like a stent, like it pops open this high-coated peak shell, and it's got a titanium inner casing. So kind of cool technology. So not all expandables are created equally, and you can see how it sort of conforms to the end plate. And I think that was probably a big reason why, even in this really osteoporotic patient, we didn't have any subsidence or any issues there. And this is another case of that similar sort of like two cage approach done by one of my buddies out in Texas. But always an option to put in two grafts, right? There's no reason why you can't put two grafts in. If the patient just needs a TLIF and you're worried about their bone quality, there are a number of different ways to kind of get around it. There are some like kind of crazy expandable cages in the axial plane. Like there's this thing called the Luna, and it like kind of snakes around and creates like this ALIF like graft. I had to do them in fellowship because one of my fellowship mentors was like really into it. They're a little bit painful to put in, but like you can get a massive graft in there. So there are a lot of different ways to skin a cat. This is another patient that had really bad bone and needed a TLIF, like 83 years old. She actually had fairly diffuse Mets, but really bad slip and even some bowel bladder issues. And so another patient that I wanted to do a TLIF on because she really needed a direct decompression. Like you can see how crazy spondylotic her facets are, and then you can see that the ligaments are calcified, and she's got like critically severe stenosis. And so somebody that was going to need a direct decompression, elder lady, don't want to do multiple positions, and so a good candidate for a TLIF. I got away from doing those bilateral cages because I felt as though if you use the right cage and you get in the right position, you probably don't need to. And I like this cage in particular because the expansion mechanism was sort of flexible, had some give. And here's her sort of 1 year post-op, and it didn't subside or anything like that. So I think that oftentimes, if you're thoughtful about it, you can get away with a TLIF. Another great indication is re-ops. So most of the time, my general paradigm, and I think this is probably the majority of the fields, if you've got a disc herniation, you do a microdiscectomy. If you have a recurrent disc herniation, do a revision microdiscectomy, all other things being equal. But if somebody has a third disc herniation at the same spot, there's probably something about that segment that is beyond repair, and it's going to be continue to be problematic. And so usually that's kind of my threshold for doing a fusion. And if you're doing that and you have to take out a disc herniation, then obviously you're already there. It's a good approach for a TLIF. And so this is a gentleman who had a microdiscectomy, did good, post-op day 33, he had a revision disc, had another microdiscectomy, did well, and then about 10 months later, he had another disc herniation, severe radiculopathy. So at that point, I'm like, all right, this guy probably just needs a fusion. Every time that happens, his L5 nerve is getting dinged, he's got a little bit more weakness. So I think it's time to just kind of get serious and take that segment. Another case, I actually don't use this implant as much anymore, but another case where I use that expandable implant. The reason I'm not using this specific one anymore is that I've really kind of gotten into navigating the entire procedure. It's another nice thing about TLIF. It takes a lot of x-rays to do like a standard MIS TLIF, but if you use navigation, you can do the entire procedure with basically 4 x-rays. And if we do any together, you'll see me do that. And basically the 4 x-rays are like AP and lateral. Once you've got your graft in, AP and lateral to make sure I've got rod above and below my screws. And that's kind of it. So I'll get into a little bit of that, but I think it's a really nice procedure to navigate. the companies that like, that have navigation platforms like 7D or Medtronic, they've like developed all the workflow and the tools and stuff so you can navigate all the instruments. So you kind of have to use a graph that's made by one of those companies, I think, to enjoy their whole like procedural solution. But it is really nice. That also allows me to use the microscope. And then I can watch you guys as if it's like being done through loops. It's pretty hard to see what's going on down the tube. And so I'm always kind of looking over your shoulder and I can't really teach you and I'm more stressed out. But it's hard to have a microscope in if you've got fluoro in because it's like coming in and out, it's getting in your way. Whereas if you nav the whole thing, having a microscope in is no problem. Then I can be over the bridge on the scope, watching you guys, giving you feedback and you know, set it in when appropriate. Okay, a few other considerations. This thing is, I think, still kind of in vogue, these pedicle-based retractors. I think they're okay. And depending on your comfort level with the tube, I think this is still far superior to like the midline takedown TLIFs that we did when I was a resident. But I don't think it's akin to this. I think that this is a lot less invasive. And the way that like tissue responds to a tubular retractor is just totally different than, putting a pedicle and just sort of scraping all the tissue away. So smaller corridor, but I think in a lot of ways, a better retractor and certainly a lot more MIS, in my opinion. If you look at like the post-op MRIs or CTs from those pedicle-based retractors, it's like a lot of tissue disruption. So better than open, but I think the tubular retractor is the way to go if you're comfortable doing it. If you do use tubular retractors, you can get this little side cut made. Not all the tubes have them, but it's really helpful to get across, especially superficial, contralateral, like this area over here, where it can oftentimes be really difficult to get a good discectomy. If you have a slotted retractor that can help you access that corridor. And then we already talked about expansion mechanism and trying to come up with an implant that's, if you're going to use an expandable cage, at least has some give to it. Okay, so when you're choosing a TLIF graph, obviously there are tons of them. I think about subsidence risk. How does it expand? Do I even need it expandable? Think about pseudo risk. So things that can improve that. And is it titanium itself? Does it have tie coating? Does it expand in a biplanar way, like in the axial plane, so you have more surface area? Do you need a direct decompression? Is it a re-op? If it's a re-op, you probably want a smaller cage because sometimes it can be difficult to get a lot of space because of the scarring, and expandables are really good in that context. And if you're using it, through a tube, obviously a smaller implant is going to be helpful as well. So expandables are nice through tubes because you generally have a smaller corridor and allows you to see things a little bit better. And obviously they're nice for revisions. But outside of that, I've kind of gotten away from expandables. But just be thoughtful about the grafts you use. So just kind of like choose a rectangular piece of titanium that has a jack, like shove a bunch of BMP in there. There are better implants on the market, and just be thoughtful about it like you would for any other graft. Okay, so let's actually get into the steps. And this is slides that I got from AO Spine just to give them accreditation. And then John O'Toole is one of the faculty guys at Rush who I kind of really thought the way he did it at MIS was slick. And so I try to do it basically the same way that he taught me to do it. And so some of this reflects what he told me as well. So, okay, so incision, as I mentioned, I like to do it with navigation. So I actually will put the PSIS pin in, and then I will just use the reference array to like draw a line, virtual K-wire to figure out exactly where the best place is to make my skin incision for both the screws and the TLIF, and kind of split the difference. A lot of folks will still use fluoroscopy. A good rule of thumb if you're using fluoro is about 2 finger breaths, or like 4 centimeters to the lateral. It's a good place to make your incision. But as I mentioned, I like to use navigation. When you're using navigation, you can just kind of use the reference array, and then from the scan, you can figure out, okay, like that upper left-hand corner, that's sort of like, for me, the ideal docking place right on the lumbar facet junction. And then you can also plan out your optimal skin incision for screws and kind of split the difference. So that's sort of what I meant to demonstrate there. That's actually from when I was a fellow. And then, okay, so you do your traditional MIS dilation. And once you've done that and you've gotten your tube in the correct location, then you should be looking at something like this, where you're basically on the lamina facet junction. You see IAP, maybe a little bit of lamina, and SAP. All right, let me see if I can get this to work again. Okay, good. Okay, so First step, you can do it a number of different ways. I basically like to do just a laminotomy, and then I take the laminotomy basically to the end of the flavum rostrally. So you kind of, do your laminotomy, and when you start getting a little bit north, you'll start to see like some epidural fat, and you're kind of at the level of where the flavum is going to end. When you get that north, and if you just start coming laterally to the pars, which is usually what you're trying to avoid, injuring the pars, but if you just come through the pars laterally, kind of make like an L cut almost, and you can do it with Kerrison's or the drill, then you can just get the IAP off, which is the most important first step to the procedure. What about? So when you've got the IAP off, and this is, a diagram of it being done with the drill, then you're looking at the SAP, which is the next step. And the nice thing about the SAP, when you have a view of it like this, in particular, I like to keep the ligament down if I can, because then you're kind of protected. And you can start to drill it off. If you're going to drill off the SAP, the only thing that I would say you have to be cognizant of is if you're not kind of knowledgeable about where you're drilling, you can pretty easily just start drilling into the pedicle, which obviously you don't want to do. So you can take a quick x-ray and kind of get an idea of where it is, or you can use Kerrison's, like 304 Kerrison's, particularly if the ligament's still on, you can be pretty aggressive. And then the Kerrison obviously is not going to go into the pedicle. It'll help you kind of skeletonize the pedicle and create a nice corridor. Okay, so a couple pitfalls here. The pars is deeper than you think. So you're like drilling laterally and you're like, what's going on? Like, it doesn't seem like the IAP is really like released. So it just is much deeper in thickness than you would think, but also in plane. So you have to just get a little bit more depth to really get the pars drilled down. And you don't have to use the drill. I think for that reason, some folks will use an osteotome because it's a little more obvious, right? When you get across with the osteotome, you can kind of feel it go. I just like using the drill. I think it's pretty quick. But certainly I've seen folks do it with the osteotome. Some of the folks in my fellowship did it with the osteotome. And I think it can be done safe, but you really probably should do it under x-ray. And the reason being, obviously, is that there's a ton of pretty critical neurologic structures there. So you don't want to injure the exiting nerve root. And also, if you're not precise with it, you can get into the pedicle and cause issues. So basically, you want to use the osteotome and just, if you're going to use it, line it up just cranial to the pedicle below or just caudal to the pedicle above. So you're sort of flush. And that's a really quick way to get the pars released and get the IAP off as well. And as long as you're flush to the pedicle, you shouldn't hit the traversing nerve root. But just be careful. Okay, so like we discussed, you got the IAP off. We've started to remove the SAP. That blue dotted line is basically where the pedicle lies underneath the SAP. You skeletonize that. Then you're looking at the flavum underneath. You relieve, at that point, then you can release the flavum. If you're doing an over-the-top decompression, you can do that before you do the TLIF. You can do it afterwards. It really doesn't have much bearing. But let's just say you didn't need to do an over-top decompression in this case. So then you're basically looking at the disc. You can see the thecal sac and the traversing nerve root. You can see the exiting nerve root there. One thing about this, when somebody's got like a grade 2 spondylolisthesis, oftentimes the exiting nerve root is sort of pulled down with the vertebra above. So in terms of depth, it's in the same plane as the disc, which is maybe counterintuitive. So you just have to be a little bit careful when you're working with the disc. The exiting nerve root can be pretty close. There are some folks who feel like you have to find it and like put a patty on it or something like that just to be sure that you know where it is. I think that's very reasonable. You can always go up to the pedicle above. And if you're there, it should be pretty easy to find the exiting nerve root. I don't think you necessarily have to find it. I feel like I almost always do find it just because you're in that corridor and you're doing your dissection and you find it. But I think it's okay to not find it, but definitely be cognizant of the fact that there's a very delicate nerve root, dorsal root ganglia, very close to where you're putting in these shavers and grafts and so forth. I think that this is me just describing what I just told you guys. Be careful of the exiting nerve root. So now you're starting to do your discectomy. Once I'm done, I think the bigger the annulotomy you make sharply, the better, because then you're going to just have smoother passage. And so I try to get pretty flush onto the end plate of the level below. Sometimes there's an osteophyte there you may even have to take a few bites at, but you really want to make a good annulotomy to begin. Very similar to how you're doing a lateral. You want to make sure you get a good annulotomy to start. And then you start to do your discectomy. Similar to lateral, I don't spend a lot of time messing around with pituitaries and stuff and just get a couple bites, then I go right to the shavers because they're going to be much more efficient instruments than a pituitary. When you're starting to do that though, like the natural tendency is to have like this kind of normal corridor where you're ipsilateral and superficial and contralateral and deep, and that's what the tube is showing you. And so that's where you do your discectomy, but you're neglecting the ipsilateral deep and contralateral superior areas of the disc. And so that's why you'll see some of these reports for like when people do TLIFs, they like remove like a third of the disc or something like that. You can do a lot more. You just got to be thoughtful about it and kind of thoughtful about where your blind spots are. So oftentimes when I'm using the shavers, I'll go with the first pass in the trajectory of number one, and then I'll just loosen the table mount, go more orthogonal, and do the same thing going down. So I get that ipsilateral deep stuff. And then to get the contralateral superficial stuff, I'll just use a downgoing curette to kind of get underneath the annulus and try to push disc away. And if you do that, you should be able to get the majority of the disc out. Pre-pack, post-pack. I like to pre-pack. If you're using 2 cages, you really shouldn't pre-pack too much because it can be hard to get everything in there. But I've moved away from the 2 cages for the most part. I'll just use one. And then you should have enough room to pre-calf. And you should have a lot of really good graft, right, from taking down the facet. So that's one nice thing about the procedure that you should use to your advantage. This is the only procedure outside of pseudos and things like that where I use BMP. So I do use an extra small BMP just, again, because you don't have the same surface contact with the bioactive in our body. So I will put some of the autograft from the vasectomy, an extra small BMP patty. Oftentimes I'll cut it in like thirds, and I'll put 2/3 of it in the inner space, and I'll put the other third in the contralateral facet. Just try to get some bone growth there. But you definitely should pre-pack, and then you place your graft, which is pretty intuitive. And then if you do need to do an over-the-top decompression, I think most people prefer to do it afterwards. You could do it before, but obviously you're right there, so you can just swing your tube over and do the decompression, and then you're good. So what about screws? So I think if you're using fluoroscopy, most people would prefer to just do the TLIF and then put in the screws at the end. Because if you have a bunch of tulip heads from an MIS tulip sticking out through the skin, then that's going to be in your way, and it's going to make it hard to get the tube down. Now, if you're using one of those pedicle-based retractors, obviously you're putting the screws in first, right? The way I like to do it, because I'm navigating it, is I'll put the screws in. So I'll put the PSI pin in. I'll put those screws in right out of the gates, and then you at least have, like, say it's a really cleft disc space, you can distract off those screws a little bit. And the navigation fidelity is really good because you haven't done any inner body work or anything like that. And then contralaterally, I will just cannulate the pedicles like a all tip tap. And I will, like, if you use the first dilator, you can actually drop a K-wire through that dilator into the pedicle. And if you do occasionally, I'll show you how to do that. But then you have basically pedicle fiducials in the pedicles, ipsilaterally to the TLIF. You've got the screws in contralaterally. You can just bend those K-wires out of the way. This is a picture of that case I did with Ryan where we did it on both sides. So in that case, we didn't put in any pedicle screws. We just cannulated them all, bent them out of the way, dropped our tubes, and having the navigation, even for the decompression, is really nice. Even if all of your instruments aren't navigated, it's just kind of nice to know where you are. But again, I've moved towards trying to navigate the entire procedure. So this is screws. I know it's kind of a throwaway slide. This is a TLIF, another throwaway slide. Okay. So new for 2024. I've got a couple updates just to try to keep it fresh because otherwise this talk is kind of stale. Any questions about just like the technical components of the procedure that we went through?
Where do you like to make your laminotomy? I know, or sorry, the annulotomy. I know people use like medial border of the pedicle, like as a start point and then go.
Yeah.
Was that? Do you similarly do that, or?
I try to get like so it's a little bit different for everybody. You know, if somebody's got like say I'm doing it because and they've had a decompression before and there's a lot of scar, then I generally don't get as medial just because there's so much scar and stuff to contend with, and I'll go basically as lateral as the exiting nerve root will allow. That aside, I like to make the annulotomy pretty medial. So I would go basically to the border of the fecal sac, maybe a little bit beyond it, just because when I'm placing the implant, like I will have a retractor on the fecal sac. And I just feel like if you've not made a big enough annulotomy, then you have to use a lot of force. And I worry about that impaction force causing like just like a mechanical injury to the nerve, either traversing or exiting. So I think the bigger the annulotomy, the easier your life will be. So I try to make it just a little bit medial to the fecal sac, and I try to basically take it as lateral as I can without putting the exiting nerve root at risk. So I try to make it big. It's a short answer. And I think that will just make your life easier. Okay, new for 2024, in addition to you guys. So at Estimus this year, it was kind of cool because the opening section on Thursday night, which is usually one of the like better attended sections, was all about TLIF and sort of the history of it over the last 20 years and what people are doing differently now, what they learned over the last 20 years. And so it was a cool session, and I learned, I think, a lot of kind of interesting things, a few of which I want to go through today. So endoscopic TLIF is like the hot thing. I don't know if it's still hot. I mean, it's been like the hot thing for like the last decade, but people always want to talk about it and learn about it. Is it the future? In my opinion, no. Um, and there, it definitely is like out there in the market. I just like Googled endoscopic TLIF to see like what came up, and this is like some private practice, and I don't know. There's like this like camera and all these ribbons because he went to the ISIS meeting. I don't know. It's like kind of silly marketing stuff, but it's definitely something that's marketed and it's out there, and you'll see a lot if you go into the community and do private practice, and you can see that it reduces time and minimizes blood loss and pain and speeds recovery time, reduces chances for complications. I definitely think that that's not true. But despite the marketing, there is some like actual academic work, some literature that looks into this. And I mean, if you look at these different studies, they pretty much all say the same thing. I think none of them have long-term follow-up, which I think would probably favor the non-endoscopic TLIFs because they're probably getting better correction, better grafts, and so forth. But it takes longer, but it can reduce blood loss and hospital stay, but it doesn't really change the long-term outcome, is the main takeaway. Bob checked me with this guy, Ray Gardaki, who's like one of the godfathers of endoscopic spine surgery. And like, as you can see, he almost looked like an NFL football coach, like a very like cool guy. So,
USC baseball player.
oh, was he really? Not surprised. Yeah, not. I would not. I'd probably bad at football. So because he's been with like, yeah, he's also like a very cool guy, very approachable guy, and so
Really?
I'm actually very interested in endoscopic spine, and I want to kind of figure out a way that we can bring that to scripts. And I do think that there's a lot of value in the decompression space, and just for like far laterals and for some discs. And if we get, slick enough and calcified thoracic discs, maybe posterior foraminotomy. So I think there's probably definitely a value play there. And I've done a couple labs, but like anything else, got to make the numbers work and stuff. So I do think endoscopic spine has a role, but even Gardaki, because I was talking to him about the different platforms and what would be a good way to potentially invest to get it here at Scripps, and I just asked him about TLIF, and I think even he's doing like 80% through tubes, and he's doing like 20% of his TLIFs endoscopically. So it really has to be the right patient for it to make sense, right? It can't be somebody that you need to have a ton of lordosis, take down both sets. You're not going to do that endoscopically. It can't be somebody that I guess it could, but if somebody needs to have like direct decompression over the top, like it's going to take a long time doing all that endoscopically. So it's like a patient that basically needs a spondy reduction, probably doesn't need a direct decompression, doesn't need a ton of lordosis. Like it seems like a pretty narrow corridor. So that's why I think it'll always be limited. But it's cool, it's interesting, but I don't think it's gonna have like a ton of staying power for most patients. So I don't think it's like quite this dramatic. Like you could learn to type your feet doesn't mean it's a good idea. But just because like we can do certain things doesn't mean that they're always the best modality. So just be cautious of that. Okay, so expandable versus static. This was kind of a cool paper. I don't think it's even in print yet. September 28th. It's just like online, but it was a pretty cool study because it had quite a few patients. So 306 static versus 111 expandable, which was like twice the size of the other cohorts. And the expandable cages, as you might think, were associated with increased changes in disc height relative to the static cages in very short-term follow-up, so like post-op and at 6 months. But by a year, those differences were no longer significant. And that largely resembles my experience with expandables, at least those static, titanium ones. I think that if you had a more forgiving expandable cage, it probably wouldn't be this dramatic, but essentially it's not sustained increased disc height change. And then it didn't really change any of the lordotic parameters, which is sort of interesting as well. So I think it's less about static versus expandable. It's more about the actual procedure, where you get your graft, what you do to the facets, if you compress, etc. And then this is the last thing. So we're running a little bit over here. I just wanted to talk about. This guy is actually a pretty cool guy. I met him at the SMIS meeting as well. He was one of the speakers, and he's from WashU, and it's kind of a TLIF guru, and just a really smart guy. And he talks about this thing transfer set MIS TLIF, which I never really like was able to conceptualize or think about. But since he was right next to me on the stage, I kind of asked him about it, and the I guess I was never I was never able to conceptualize why. Like, why would you do a transfer set? And his main takeaway was that if you keep the actual procedure within the confines of the set, then like you can be pretty aggressive. And so what he means by transfer set is he creates a small corridor. So you basically need to have an expandable cage because it's such a small corridor. But you don't take down the IAP. You don't take down like the medial bone, and you just create a working corridor within the facet, which does give you access to the disc space. And so then you've got bone medial protecting your traversing nerve root, you've got bone lateral protecting your exiting nerve root, and you can really kind of like go to town. Now, if you need to do a decompression subsequently, once your graft is in, then you can take down the IP and do a laminotomy and all that stuff. But this is a way to kind of get a cage in there safely from a neurologic perspective if you use expandable cages, and kind of just a cool variation on the technique. I need to get a new slide. I've got another child since then. So any questions for you guys? Isn't that outfit though kind of amazing, the doctor thing? Questions, thoughts, concerns?